All right. So last time for the frozens, we sort of did kind of snippets, little individual biopsies here and there that, at the end of this, of course, I'll provide you this full link. But I thought today we would go into more of the case where you're actually dealing with some kind of resection, whether it be the main specimen or bits from around the main specimen or a conglomerate of both. And so many of you are already very familiar with sort of these tongue ellipses that come for quote unquote deep margin. And so I wanted to sort of go over a little bit again, the thought process behind this, how we approach it and why. And so, this is an example of one that came for frozen, that was nicely oriented, by the surgeon, and has this obvious defect in the middle. It's very tidy. There's a little bit of extraskeletal muscle on the side, right? And so this is sort of a classic example of that process. They basically want to know a few things, right? They want to know, could there possibly be severe dysplasia or carcinoma in situ at a mucosal margin? However, most of the mucosal margins, as we see, will be taken separately in the little strips later. They certainly want to know the presence of any invasive carcinoma, either or both at the peripheral margins and or at the deep margin. They say for deep, and this is the most important one. The peripheral and the mucosal are a little bit secondary because generally these get covered in the secondary strips that they take as quote unquote tumor bed margins. Okay. Sometimes they're asking for the depth of tumor invasion to determine if the patient needs a lymph node dissection or not. And if they're asking for that, they will certainly say that because that's not a standard ask. The standard ask is just deep margin. So any severe dysplasia or carcinoma in situ at a mucosal margin, whether it be from the main specimen or the tumor bed, is considered, quote unquote positive. They'll go back for more. If you're dealing with a peripheral or a deep soft tissue margin, it's thought that tumor within up to 5 millimeters could potentially be considered positive depending on the clinical setting. So this isn't like prostate, like thyroid, where you have to see tumor on ink. Really anything close is close enough. And so 1 millimeter is definitely always considered positive. 3 millimeters is mostly considered positive, and sometimes up to 5, but generally between 1 and 3 is a positive margin. If you're looking at depth of invasion, a depth of invasion of 3 millimeters or more will prompt a neck dissection due to increased risk of nodal mets after depth of 3 millimeters. And so we'll talk later about how to measure depth, but more importantly now we'll talk about how to deal with these and what to look for. So I won't belabor these because I think you guys are pretty well versed in doing these, but essentially, we sort of want to gross them fresh, right? And so if you have an anatomic orientation of the ellipse, that's preferred to maintain anatomic orientation as opposed to a clock face, but a clock face is always fine if you're strapped for time or understanding or whatever. Certainly, ink the peripheral and the deep, your two colors like you normally would, and basically serially section the entire thing. As I've told many of you, I advocate taking the first and the last quote unquote tip slices a little bit deeper or thicker so that they are easier to subsequently serially section perpendicularly, right? Meaning, where's my little pen? Meaning in this direction, right? So if these are very, very thin, they're going to be very, very hard to section in this direction. So I say it's okay, take them a little thicker than you normally would for your individual slices. All right, so central sections, of course, should be taken at approximately cassette thickness because you're going to want to be ready to just submit these straight away after, if you can. Some of you have used the liquid nitrogen technique where if the specimen is kind of boggy or floppy or really fatty, Kyle Parker used to do this. He used to like it. Sort of preparing yourself a styrofoam container of liquid nitrogen, and then gently immersing the specimen in it, so that it firms up, so that it's a little bit easier to section. And then once you have the sections, they thaw very, very quickly. So you can select your sections to freeze and freeze them quite easily. This is mostly for things that are, a little bit harder to cut, or if your technical skills are such that you don't think you can get slices that are, thin enough. This has worked for some people. You can do that for skin, you can do it for mucosa. It doesn't really affect too much of the, can we use it for breasts? So, I would run that by the breast pathologists. You may want to try it on I don't know, maybe take a lump of fat from, I don't know, maybe an autopsy or a leg. I haven't really done it on specimens that are 100% fat. I can't see why not. I think you probably can. I don't think it affects the morphology significantly enough to not do it. People have asked, oh, but you're freezing the tissue. Like, doesn't that screw it up? I don't think so. But, I'm looking for different things than, breasts. So you might want to give it a shot, and show it to them, maybe cut it, process a few sections with Ryan, and see how the permanent histology comes out after freezing. Because I think that's the gold standard, right? Is if you freeze it and thaw it and then submit sections from that, what does it look like? So yeah, I would try it out. I'm happy to look at the stuff with you. I'm curious. So yeah, I support a trial of that. Cool. So once you have your specimen, we used to do it a lot at MGH, let me just say, for like skin that had a lot of underlying fat, honestly, and those turned out fine. So yeah, that's my 2 cents. Okay, so once you have your serial sections, what will you freeze? Obviously, my white is trying to represent tumor. And so you're certainly going to want to freeze some tumor that's approaching 5 millimeters-ish of any margin. So you may want to think that slice 3 has actually the closest to this black peripheral margin. So you may want to freeze, at least this portion of slice 3. Slice 4 has the closest to the deep. So you certainly want to freeze that portion of slice 4. If it's really, really a deep slice, you can always do just the bottom half. That's fine. But most importantly, you want to get approach of tumor to that ink. These are blue arguably is quite far, so I wouldn't even worry about freezing blue. And then whether or not you freeze the tips is going to depend on whether there's tumor in that tip slice, right? So if there's really no tumor in the tip slices, then I arguably wouldn't even worry about it. If there is tumor in the tip slice, then I would section it and evaluate how close it comes. If it's far, you're fine. If it's close, I would additionally freeze that, just to be safe and sound. Mostly they're concerned about sort of the 3s and the 4s types of things, but certainly the tips could come into play if the tumor is quite close. So here's an example of, why is it taking so long? The cut sections from the one that I showed you in the initial. So in this case, which one would you think is close? Slice 1, slice 2, or slice 3?
3.
This 3 is making me nervous. Yeah, I mean, yeah.
3 is probably the closest. So, if you sort of consider, tumor to margin is probably that, tumor to margin is probably that, and tumor to margin is probably that. So yeah, I'd say that's a good shot for the closest. And so here's what it looks like. So, as expected, right, you have your mucosa kind of around the top and side, and then you have your tumor here, and you have nice ink. And so, I mean, this is this is a very, very clean, well cut example. If you don't have a nice intact, inked deep edge, keep cutting deepers or make sure your tissue is oriented appropriately, because you really want to make sure that you can measure this distance. Because just saying, oh, it's not touching ink, as I said before, it's really not enough. You want to be able to measure a distance. And so here, I would say the distance would be, basically from here to ink. If you, I like, oh, does this even have measuring? I like using the microscope objectives to measure distance, because they all have a standard, diameter. And so you can sort of gauge based on the diameter of your objective how far something is. Certainly you could use, dots and a ruler. But as I think you guys are pretty much okay with using those objectives to get that distance. So that's that. What do we do about depth of invasion? So in this case, depth of invasion was not an issue, because it was already known clinically and radiographically and on biopsy or whatever to be deep, right? This is certainly more than 3 millimeters. So this patient would get a neck dissection anyway. But if you are asked to measure depth of invasion, I just wanted to go over what that would mean. And so we already said that 3 millimeters is essentially an important cutoff. And it's measured essentially from the adjacent normal, quote unquote, reconstructed basement membrane to the maximum depth of invasion. So you can see here what to do in cases that are sort of flat. That's very easy. You sort of draw a line from the nearest basement membrane down. If it's exophytic, you don't want to count the exophytic part. You just want to count from the basement membrane down. And similarly, if it's ulcerated, you don't want to count from the ulcer base. That will give you an artifactually low depth. You still want to count from that gold standard bar, which is the basement membrane. So if you're ever asked to do depth of invasion, make sure in your sections, if you can, to get adjacent normal, because if you don't get adjacent normal, you're never going to be able to give a good depth, because you're not going to know if it's exophytic, endophytic, ulcerated, whatever. So that's why I'm showing this, so you know how to sample those areas. So here's just an example of that here, where you draw your horizon line and then your sort of plumb line. Here's an actual clinical case, where the horizon line is pretty easy. The plumb line is the depth, and then the red line is the distance to margin. So in this case, you have all information. If a tumor is large, you may not have all of the information on one slide, but cool. And so then this is just a permanent of that same tumor that pretty much recapitulates the same thing. Distance is still clear. And yeah, I don't know why I'm showing this, except to show you that this case was a very nice recapitulation from frozen to permanent, and everything stayed, the same. So then, right, you're also going to get these mucosal strips. So as you know, the mucosal strips are called, quote unquote, tumor bed margins. They are taken from the edge of the cavity that's left in the patient, and they are not always oriented. So what does that mean? So once the surgeon takes out this main specimen, there's a hole, right? There's a defect. And these strips from around are taken from the margins of that defect. Mostly, these pieces have a thickness, right? But they are not always oriented in terms of which side is closer to the specimen that they just sent and which side is actually still in contact with the patient, right? So each strip has a non-margin side and a true margin side, but unless it's sometimes Dr. Blair orients these, but most of the other surgeons don't. So sometimes what Dr. Blair will do, will put ink, for example, on she'll say ink on non-true margin side. So you'll see her strip of tissue and it'll generally have some like blue ink on one of the faces. And however she's indicated, if she says, ink on non-true margin, that means ink is facing the main specimen and non-ink is the actual new true margin. So in this case, if it's a thin specimen, I would advocate, whether it be for frozen or for permanent, I would advocate embedding it with the not true margin side as the first slot. Sorry, I take that back. I would advocate embedding it such that the true margin side is what we see first on the cut sections. So because if anything is present, here or a millimeter from here, that will be considered positive, and we want to know. If something is present, at the not true margin side, I don't really know how that relates to the true margin. So I always advocate freezing the true margin side such that slice gets cut first, right? So putting that true margin side face down in your permanent cassette, right? Or also still face down in the well, right? Because that's what you're going to pick up and freeze. If you don't know which is the true margin side and the not true margin side, then it doesn't matter. Then just sort of pick one, because you're never going to be able to know. Does that all make sense? Okay. So invasive tumor, or, dysplasia / in situ in that section is going to prompt additional margin re-excisions. So if you have a frozen of a tumor bed that is positive, generally what they'll do is they'll take another one that they'll send just for permanent, and then they'll take a third one that they'll freeze again. So for each positive tumor bed margin, generally I expect 3 specimens. Sometimes they don't do this middle second one. Sometimes they just do one more. But generally they do an intermediate for permanent and then a final for frozen, just to make sure they're decently far away from the tumor. So, if this is, posterolateral 1, this is posterolateral for permanent, and this is posterolateral 2 for frozen. They sequentially should be sort of considered in this order, with this one being the final true. Does that all make sense? All right.
I think so.
Cool. So then in the next couple of slides, I have some tumor bed margins that I wanted, hopefully, if anybody wants to drive them, you can, otherwise I'll just do it. No volunteers.
Maybe if you want to do it in the interest of time, just so we can get through maybe more of them.
Good. Yep, that's fine. There's not that many. All right. So I'll just start at the surface and let you guys look, and you can tell me what you think. Have you guys been having this problem where there's like a blurry water line and it's just blurred on one edge of that line?
Sometimes, yeah.
Why is that happening? I'll have to ask Phillips about that. That's insane. It started recently.
It started recently.
I
had issues with scanning slides for a project, but it wasn't like a water line. It sounds like this is different.
Does the water line happen only when you export the slide, or does the water line happen also when you're viewing it in the Philips online viewer?
My issues, oh yeah, Jasmine's saying discrete waterline. My issues were just within the viewer. I didn't export it. I don't know
Okay.
about
So
other
it's not
people.
like this happens when I export the slide to Path Presenter. It's just, it's there. So it's a problem with, okay. It came up in my snips of the Phillips. Okay. All right. I'll find out. If you have case numbers, Jasmine, that you know they are present in, can you send those to me? Thank you. Okay, so sometimes when I'm looking at these tumor bed, quote unquote, margins, I sort of ask myself, you know, a very, very, very basic question. Is it something or nothing? And so is there, the most important thing to ask yourself is there invasive or in situ carcinoma?
Oh. No.
No.
Look like it.
Right. So great. There's no invasive or in situ carcinoma. So then at that point, you're probably mostly in the free and clear because they're not going to do anything without invasive or in situ carcinoma. I've got called, you know, a number of times on these types of specimens where there's some basal atypia, there's some, you know, nuclear sort of orientation disorganization, and asking me, you know, what do I do? And what would you guys do in this case, for example?
There is no dysplasia.
We have one vote for no dysplasia.
I mean, I guess if you're concerned, you can always do deepers.
Concerned for what?
Well, I mean, I guess if you're concerned of invasion, in this case, I think there is dysplasia, but it doesn't look so high grade. But I mean, like maybe except for this area here, see if it all lines up.
There's also a little chronic inflammation. I don't know if that colors our perception at all or
Yeah, probably not enough to the extent
not
that
enough
it's
to, yeah,
having
to
the effect.
like,
Yeah. So yeah, I mean, this kind of stuff can be, it depends on how broad of a brushstroke you want to provide. And so I completely agree with you that there's no in situ or invasive carcinoma here. So you're pretty much in the free and clear. Sometimes they will ask you if there's dysplasia. I've had this happen on occasion. And sometimes they will go after, you know, moderate, you know, to severe dysplasia. I would argue that there is dysplasia in this case. Unfortunately, that's blurry, but you know, there's some expansion of basal layer with a little bit of disorganization. There's a little bit of, you know, architectural sort of irregularity and budding, as in this area. That doesn't necessarily mean invasion, but it can be a clue to some level of dysplasia. But yes, I think if you were to sort of give this a two-tier system, you know, low or high, I would put this in the low, and I would say that this would not be something that they would necessarily worry about. If you're on the fence between mild and focally moderate, fine, whatever, as long as it's not, you know, severe or in situ. And I don't think they're going to be splitting hairs to this extent. So as long as you call this negative for carcinoma, that's fine. If you call this mild dysplasia, that's fine. But, you know, people hem and haw over this stuff sometimes at Frozen's. And I generally say, you know, is it something or is it nothing? And if it's not something, then it's probably nothing. Even if it is mild dysplasia, that is essentially in this context, generally considered nothing. Okay. Then there's this guy, which I think is not quite as well oriented, is a little more fragmented. Still hyperkeratotic. Oops, wrong way. All right, something or nothing.
Something
Looks a little more dysplastic than the last case.
looks pretty disorganized. I mean, again, the
Yeah.
orientation's not great, but at least in that other section especially, it
Yeah, the
looked
last
pretty
one.
jumbled and like potato-y.
Mm-hmm.
The section to the left or to the right?
You're talking about the one to the
The
right.
one to the right, at least
Yeah.
that was the one that I saw a little
Yeah,
bit
this
better.
You can see a little more
It seemed, yeah, I thought we got a slightly better cross section maybe, although it's still kind of not the most perfect orientation. But yeah, I felt like this made me quite nervous.
so spongiotic. And
Right. Yeah, there's definitely some edema spongiosis. There's definitely some, quote unquote, pink cell change where some of these cells in that spongiotic area have acquired some dense eosinophilic cytoplasm, which could also be sort of a sign of dysplasia.
so those are
Yeah.
dyskeratotic cells where it looks
Essentially, yeah. Maybe
maybe
a mitosis. Yeah, this to me honestly is a bit challenging just because of the very poor orientation. And once you see these almost network like cut pattern, right, where you have these reedy poking up, that it's tangentially sectioned, right? That these reedy poking through mean that this tissue is not well oriented. But even in the places that it's not well oriented, yeah, I agree. There's definitely a lot of disorganization, some potato-y larger nuclei, some dyskeratotic eosinophilic cells. So this might be one where you definitely might want to get deepers, or at least as you guys are doing, expressing some concern about, maybe this is not nothing. But
disorientation is because of the embedding
yeah.
by the
Sometimes it's embedding, but sometimes it's just the way that the tissue is sent to us, where we embed it pretty much as we receive it, and it's just a matter of how it's cut, out of the patient. Sometimes there's not a lot we can actually do if it's cut surgically at kind of odd angles, or twisted or turned and sometimes folded in the process of sending it to us. So yes, if you can, flatten it out as much as you can and orient it and embed it as cleanly as you can. But honestly, sometimes these can be really challenging because they're so like raggedy, that it can be really hard to orient. Yeah. Especially something like this, that's actually mostly surface and not really any stromal interface. Like, I don't even know. You just sort of, you can't really tell what's up and what's down necessarily, because it's all just keratin, but focally. Okay. Good.
in this slide there are 3 tissues, so we can put like this 3 tissues in one chunk while doing frozen.
As long as they're from the same container. Yeah. So obviously don't ever put tissue from different specimens in the
Yeah.
same chuck. But if you have multiple fragments, or if you have a really long strip that you segment into parts, yes, you can freeze them in one chuck. It mostly is a matter of your comfort level with embedding and cutting multiple pieces of tissue. But it's definitely allowed. For sure. Okay. What else on this case? I think that was it for this case. So yeah, so this case had a clean negative margin deep and some variable amounts of dysplasia in the surface. And I agree that this is probably a little worse than the other. Okay. All right. The next one is an interesting one. This is from the mandibulectomy for squamous cell carcinoma. And so the first one you're getting is a biopsy of a lesion on the retromolar trigone, which is this guy.
Squamous cell carcinoma.
Yeah.
This is very worrisome. Yes, it's
Yeah.
Maybe even
all over.
invasion.
Yeah, it looks worrisome, highly.
Oops. Yeah. So sometimes on occasion, they will either send you the lesion because for some reason we don't have like we haven't reviewed the outside preoperative biopsy or something, and they just want to make sure that we're not, completely off base. So sometimes they'll send you the lesion and just to confirm, yep, this is it. And then they take the specimen out. Sometimes they see little areas in the mucosal surfaces that are not the main lesion, but like separate and like, oh shoot, there's something else in this patient's mouth. Like, do I need to chase that as well? So sometimes you'll see things like that are like completely not even what they were going for, but they want to make sure is not something that they have to go for. So sometimes, those will be obvious or not, but sometimes that's what you might get. So yeah, that was at least called, I think, suspicious for carcinoma or favor carcinoma. Okay, then we're getting an anterior mandible. So they're like, okay, fine, it's cancer. Okay, I'm going to take the mandible out. Now we have an anterior mandible margin for frozen. So, what they do, no, this is just the permanent. Sorry, this is the permanent of that before we move on to the mandible. So yeah, the permanent, I think you guys can agree, is pretty clear. Yeah, for cancer. But I'll send you guys this one. There's nice, really ugly cells. Okay, great. So that's the permanent. All right. So then they send you the anterior mandible margin. And so what does that mean? So if you think about when they're cutting through the mandible, right? You have cortical bone, on three sides. You probably have a tooth here. You have mucosa. And so what they're sort of trying to do is they're basically taking stuff from here. They're chunking out the marrow of the mandible to send to you to try to freeze. So you're obviously not going to freeze cortex. That's just impossible. And they know that. So they're trying to get some of the more softer marrow stuff that you can actually freeze. But just like when they take, for example, a little tiny piece of skeletal muscle from the deep margin of a tongue, just like this for the mandible, they may only take, a tiny little portion of the face of that mandible that's not really representative of this whole surface. And so that's sort of what I want to show you guys here. So this is a little speck, right? This is a fleck of marrow with bone from that site. And so if there's small chunks of bone, I think they can cut okay, as you can see in this case. But you want to be looking for anything that's epithelial, essentially.
That's squamous.
That's squamous epithelium. My question for you, I guess at this point, is what are you going to do with it?
It's benign. I don't think anything is there.
It's hard to tell. It looks sort of superficial.
Yeah, it doesn't look as bad as the other
Hard
portion
to
based
know.
on.
Yeah, it looks pretty well differentiated, pretty bland. I agree with that. So that's the problem sometimes with these fragmented marrow margins, is that, one, you are not expecting to see epithelium at all in these areas because they're not at this mucosal surface. They're in the bone. So seeing any amount of epithelium at all should honestly potentially clue you into something. Now, I'm not even sure. Go ahead.
Oh, sorry, I was just saying, like, and we. Oh,
Sorry.
no, go ahead. Sorry.
I think like well-differentiated squamous cell carcinoma metastasizing inside, entering the bone could look like that.
That's exactly the question. If you have bony invasion by a well-differentiated squamous cell carcinoma, and it's traveling through to that margin, could this be tumor?
But
Would
doesn't
it-
it
I
look like
guess-
the surface maturation sort of, you know,
Yeah, I guess my question was similar, like, is this contaminant, although it looks like,
Yeah, so contaminant is definitely a possibility if it's not attached.
yeah, but it seems
To
like
the
it is
tissue.
attached here. It seems like it's connected nicely, doesn't it?
I
So,
think at least here, the stupid blurriness, at least here, this looks to be, these epithelial cells look to be in
yeah,
continuity.
like they're
with
hooked up with
stroma.
that stroma. Yeah,
No.
yeah.
But I don't know that I can even give you a straightforward answer on this because this is extremely challenging, right? This is extremely challenging. So if you have a mandible, right, and they're cutting through it here and here, and here's the bottom of it, and your tumor is invading the mandible, and your tumor is traveling, right, undermining and traveling in either of these directions, it can be positive at any one of these cut segmental marrow margins. Especially challenging in this case if it's extremely well differentiated. So here's the permanent remnant. Here's the permanent remnant.
oh my God.
Something's still there.
Yeah, it looks more convincing that this is.
Oh yeah, here it's like
Involvement.
enmeshed. Yeah, this is far more convincing.
So blurry, but yeah, you're convinced that that's epithelium surrounded by stroma, yeah?
It looks like even like a desmoplastic stroma.
It
Maybe
looks like a
little,
desmoplastic
maybe.
stroma,
I don't know.
exactly. Yep, let me see if it's clearer over here. So what I did levels on this case because I was like, oh man, that looks like
Yeah.
epithelium that's atypical, that's embedded in desmoplastic stroma. Exactly. So that I think is what was on the frozen.
God.
It's scary because this frozen was called, I think it was called, rare atypical squamous epithelium favor benign, no obvious cancer. And I can't blame that person. Like that was a hard call. When you're not sure if it's detached or attached, and it's so maturing, it's so well differentiated. But then on the permanents, you go and you say, oh shoot, that's atypical. And not only is it atypical, but it's now also embedded in desmoplastic stroma. So this is that, yes, this is a positive margin. What is fascinating is that Blair sent more mandible marrow margin,
Great.
say that 3 times fast, for permanent.
Wow.
And this is it.
Alright.
So
This is
all
like a
that bland
textbook case.
textbook, all that bland looking
Oh my
stuff
God.
that you saw at the edge is this well differentiated invasive carcinoma.
Oh
It's
my God.
it's insane. Like I was floored. I thought this was a very, very, very educational case. And I don't think anyone is going to argue that this is cancer. And she's, she flopped this from the mandible. Here's a little bit more cortex, certainly that would not freeze. But this kind of woven bone with tumor, that kind of stuff theoretically could cut. It just wasn't sent to you. What was sent to you was much less representative of the actual face of that mandible. You got mostly bone and fibrous tissue with like a tiny little speck, So one that I will die of, we all die of guilt at some point. And I think for me, the educational thing, right, is like, these are really tough. And this is the nature of the problem with these cases, is that there is sampling, variability. There's literally sampling error, right? And so if you're getting this, it's just not representative. And if it is representative, it's really, really hard to diagnose, okay? So this is a positive margin. Here is what the specimen looked like with the teeth and okay, keep going. All right, so there's nice craters in the teeth. Here's anterior mandible. Here's posterior mandible. And here it is from the other side. So generally, when I have you guys gross these, you know, we'll do bone margins on FOSS, right? Because it's just easier to put that whole side, you know, generally tandem on FOSS. And so that's what I want to show you guys here. These are the tandem on FOSSes. I don't remember if one of you guys actually grossed this, but tandem on FOSS of the bone. So this is the sort of bottom, you know, of the mandible bone. And this is the adjacent. Okay. So I can't, what did I want to show you here? Oh yeah, there it is. Right. So this is that on FOSS margin that we took from the main specimen that corresponds to that stuff that she chunked out and sent that was positive. And look, it's got even gorgeous perineural invasion there. So just a good educational lesson for us in this case. I think this was my case. Yeah, I think it probably was. Cool. And then I just wanted to show you this very lovely representative section here of what this tumor did, right? So where's my little, there it is. Yeah, there it is. So I believe that, right, if you look, this is dentin, this is tooth, this is not bone. All right, so we have a nice section of tooth that is sort of diving down into bone. And all you can see left here at this one edge are these residual little bony islands that the mandible has been, you know, essentially effaced by tumor. And there's only tiny little islands of residual cortical bone left. So even though it's extremely well differentiated, right, it's extraordinarily aggressive. And so this is, I guess, not only a good example of how these frozens can be challenging due to sampling error, due to interpretation variability, but also a good example of why we don't grade squamous cell carcinomas, right? Because you're going to give this a you know, well differentiated histologic grade, but this is not behaving like a nice, well differentiated tumor. This is absolutely horrifically destructive and displacing this person's mandible and highly infiltrative and with perineural invasion, right? So it's all of these other ancillary features of the tumor that in clinical practice are much more important than well differentiated, moderately differentiated, poorly differentiated. Does that make sense?
Yeah.
I think so.
What other questions do you have before I do my little wrap up here?
I guess just like for frozens in general, like
Mhm.
I guess the head and neck attendings seem very understanding of things taking a while. So I guess I always like get nervous, like, oh, it's taking too long. But I suppose, I mean, they're all very well aware that these like kinds of investigations are going to eat up a lot of time, right? Like, I guess we should not stress about time when quality is at stake, I suppose. I don't know. I guess I need a little reassurance that
Yeah. I mean,
your
I think
time is
obviously you
acceptable.
shouldn't, you know, take a lunch break in the middle of it, but
No, obviously not.
But I think especially when they send multiple, they know, you know, they know that it takes time and they're kind of almost to a point overwhelming our capacity, right? So be expeditious, but also be, cautious and thorough. And if that takes you a few extra minutes to get things right, I don't know if right is the correct word, to get things organized and stable, I think that that's fine in these circumstances, because they are quite understanding, and especially many of them actually come up, or I guess come down, to look at the specimen with you, and so that's always a good, if that, if they are ever down there, always take the opportunity to talk to them. And they're, I think you all are already good at that, but they're very, very helpful.
Yeah, they seem like some of the most hands-on of all the
Yes.
attendings who come down. So that's been nice.
Yeah. And, I know that people have come into issues where one of them will say, oh, ink it this way, or I'm concerned about that area, or whatever. And so, I would argue ink it and section it the way that we are comfortable with and the way that we discuss, which are our best practices. Always be mindful, certainly, of the areas that they are more clinically concerned with. Sometimes they say, oh, I'm concerned about this area. Say, okay, great, I will look at that area. I'm also going to look at the rest of the specimen as I normally would, so take what they say into account, but don't let it completely, destroy your normal standards of processing that we have. I have a question on vocal cord frozen. Okay, what's that?
So if it's very small and transparent, and we put eosin to make it be visible when we are cutting on cryostat.
Yeah.
So when we are not sure, when we put the eosin, then on the slide, sometimes, I mean, we don't get to know whether the tissue has been exposed after, cutting deepers.
Yeah.
And after staining, we see that, there's no tissue. So sometimes this eosin, gives a false impression that the tissue has been exposed,
Right.
and getting the tissue.
Right.
So should we use eosin or not for, very small transparent tissue?
I mean, if it helps you, yes. If it doesn't help you, no. I think everybody has a different experience and preference, but if it doesn't affect the tissue itself. So if you find that it helps your cutting, use it. If you find that it doesn't help your cutting, don't use it. The one thing I will say is, it is okay to go superficial at first to see where you are and if you have entered into the tissue plane. However, once you have entered into the tissue plane and you can see it on the slide, you may not want to stop there. It is very, very, very okay to do multiple deeper levels into the tissue in excess of the standard 2, because those are so tiny. And once you, as I've told many of you, let me sort of draw here. Once you, if this is your chuck, right? If this is your chuck and this is your tiny little vocal cord tissue, once you hit it, that's great, but you probably want to hit it a few more times to actually get into the tissue, because once you thaw it and then process it and then histology re-embeds it in paraffin, sometimes all that's left is a sliver, and you're just going to get a speck on your permanent levels. So I would advocate for more sections at the time of frozen, because it's already embedded, it's already faced, and it's already, that is the most important time period with which your surgeon needs an answer, right? So for these tiny vocal cord things, that would be my suggestion, is don't be afraid of going into the tissue, carefully, don't eat through it at the time of frozen. But if you get multiple, if you get 2, 3, 4, 5 serial sections through it, that's actually better than being too superficial and then like not getting much for permanent, because then you're not getting any information. I'd rather have you have the information at the time of the frozen than anything.
And can we ask, for these players, a small vocal cord tissue to use colorful OCT instead of the clear ones, because the clear ones make it more difficult to see.
Sure. Yeah. I mean, they don't have to necessarily, if you're coming up on a clear and you don't want to use the clear, yeah, just
Okay.
ask them to swap it out. That's not a problem. As long as you, we have multiple colors and only one clear, right? Not one clear, but there's only one type of clear and there are multiple types of colors. So yeah, for sure. That's, if you find that helpful, you can be the driver of your own sort of destiny at the time of frozen, right? If you find something is more helpful for you, that's fine, make it happen, because everybody is different. And so I used to be the kind of person that I found the colors really, really hard to cut. I hated cutting the colors. So I would like embed everything in clear and then just put like a splotch of color at the edge of the block, just to make sure I knew that I had the right, thing, right? But like, honestly, everybody's different and you got to do what's good for you. Okay. So in the last couple minutes, I just want to say, as I have told many of you, I know that these can be arduous times, especially when many come at once. But in these cases, when you've serially sectioned the main specimen, I would advocate that you gross them ASAP if you can, or give them to perhaps a fellow resident or PA who can gross them fresh without wrapping them back up in gauze and then processing them the next day, because wrapping them back up in gauze tends to make the paper or whatever, you start with a flat slice and then you end up with a slice like this because it's been rolled up in paper. So please try to gross these fresh. All it requires of you essentially, right, is to put them in cassettes and put in a gross description, because it's already been serially sectioned. So just please, if you can, do that. Of course, always use the slice numbers. That's very, 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 very helpful when we're looking at the final. I didn't know this. Yeah. So if we didn't have a case together at Frozen, I would not have had the opportunity to mention it to you. But when I do have a case with a resident or a PA, I generally at least ask them if they have time to just gross it right away. If you have to wrap it up for the next day, wrap them up so that the pieces remain as flat as they can be, and don't just do like a jelly roll. Try to fold the paper or whatever so that you have flat slices, but ideally do it fresh. Okay. All right. If it's a small specimen like this, sort of submit entirely. If you have questions, certainly discuss with me. And always, as you know, state what you did, what you froze, and what and how you submitted it. So, for example, A1FS, slice 4, representative lateral half, representative posterior deep, whatever, remainder of 4, remainder of 8. If you can, take a photograph of the specimen intact, take a photograph of the cut sections, and a photograph close up of the best tumor if you have time. In cases like this, where it's cut fresh and you're, freezing some from 5, some from 7, some from 3, whatever, it's nice to sort of have the lay of the land, so that we can go back and map things out if we need to at the time of sign out. Just one quick word on reporting these in the synoptics. The specimen margins are, of course, what you are getting from the one large main specimen. The tumor bed margins, right, are those that they send separately. So the tumor bed margins are all of your frozens and whatever subsequent tissue they took, if there was a positive on that frozen, right? So I know people have gotten confused about what does this mean? These are the frozens, all right? So this is the main specimen. These are the frozens. We often do not know orientation to true margin, as I said before. But we have to report those separately such that there's a final margin status from the specimen and a final margin status from all of the summed up tumor beds. It's thought that margins taken from the main specimen are much more reliable than just the tumor bed. And so I know we sort of in this institution have this kind of hybrid approach where they make you do, you know, both the main specimen for the invasive component and then the margins of the tumor bed for the mucosal surface component. And so that's generally the aim of this hybrid approach. Okay, other questions or comments? I know that some of you are familiar with this, some of you less, but I think it's always good to sort of re-review and make sure everyone's on the same page. Okay. I got nothing else.
Thanks, Dr. Cipriani. This was great as usual.
No, thank you guys. I will do salivary then on my makeup session.
Perfect. Yes, we'll switch. We'll flip-flop them
Yeah,
that way. All right.
awesome.
Great. Thanks, everyone.
Thank you.
Bye-bye.